I too would like to thank the organisers for inviting me to speak here today, particularly to meet old friends like Maria Jose Campos, Luis Mendao, Ana Pisco, and of course Pedro Silverio Marquez. He and I have worked together off and on for the past, 20 years, Pedro? Something like that. So it's really I'm really delighted to be here today. I've been asked to talk about, if I can find it, there we go, expanding community HIV testing and other approaches, particularly based on those which we've developed at the Terrence Higgins Trust in the United Kingdom. For those of you who don't know us, Terrence Higgins Trust was the first community-based HIV/AIDS civil society organisation, I think to be set up in Europe. Actually, we were set up in 1982, shortly after the death of Terry Higgins. We provide a wide range of HIV and sexual health services, including HIV prevention and sexual health promotion, information, care and support for anyone living with HIV, a growing range of clinical services, including HIV testing and STI testing and treatment and contraception services. And of course, there's our campaigning, lobbying and advocacy work. We have more than 18,000 members. We mobilise about 1,000 volunteers and employ about 350 staff. As we've heard today, there are some key emerging issues for HIV testing in Europe and in the UK. There is a pressing need to reduce undiagnosed and late diagnosed HIV. We know that undiagnosed HIV continues to drive new infections and that late diagnosed HIV seriously impacts on individual health and is the cause of about half of the HIV-related deaths each year in the UK. Now, the current models of HIV testing make a huge contribution, but there is more to be done. And to echo the Secretary of State's comments this morning, this needs innovation, but innovation in service design rather than in new drug treatments. We do need to create new approaches to help change the testing culture in both the most affected communities and within healthcare services. It never ceases to amaze me how behind the times the vast majority of physicians are who do not focus on HIV. They still tend to see HIV testing as different, special, as opposed to something which should be alongside all the other diagnostic tests they expect to use. And of course, we need new approaches that help reduce the cost of HIV testing services in the current economic climate, which has been a constant theme here this morning. So to put that in the context of the UK, there are about 100,000 people living with HIV in the UK, and data released today shows that 22% are unaware of their infection at the end of 2012, down from 25% reported in 2011. The two communities most impacted by HIV in the UK are gay men, where there's an HIV prevalence of 5%, but that's not evenly spread. In London, the prevalence is close to 10%, or 1 in 10 gay men living in London. And black African men and women, where the national prevalence is about 4%. Undiagnosed HIV is lower in gay men at 18% and higher in black African men and women at 23%. We know that late diagnosed HIV is also dropping over time, but they're still far too high. Indeed, over the past 10 years, 80% of the 5,000 AIDS-related deaths in the UK were due to late diagnosis, and that's a scandal. So what have we done at Terrence Higgins Trust? Well, we introduced the first community HIV testing services in HIV about 10 years ago now, and so we have a lot of experience in this field. In 2009, we introduced a paid-for HIV sampling service, and this year we've developed a free postal sampling service. Now, we only offer a postal sampling service because the sale of HIV self-testing kits is currently illegal in the United Kingdom, although people can buy them off the internet, of course. However, home HIV testing is to be legalised and regulated next year. I have to tell you that there was spirited opposition to each of these new developments by some specialist HIV physicians who, interestingly enough, when they saw they worked, adopted them. So there is a real role for community-based organisations in challenging medical orthodoxy, for if we don't do it, who will? So what's our HIV community testing model? Well, we begin with intensive stakeholder engagement with local sexual health clinics and HIV specialist clinicians, and of course our local community partners. We begin with most of our walk-in centres are community located rather than hospital based. Most are targeted at the two at-risk communities, gay men or African communities. They use the rapid test, finger prick test, and we give the result to those who walk in within 20 minutes, allowing time for pre and post-test discussion. We always ensure that we have an agreed fast-track referral pathway into NHS HIV specialist clinics for those whose test is reactive, to have a confirmatory tests and immediate access to treatment and care. And I think that's a model which is fairly standard across Europe at the moment. Our innovation this year is our postal sampling model. This brings together our HIV prevention campaigns and our rapidly growing online and web-based work. So we've developed a fairly sophisticated but easy-to-use online risk assessment which allows someone to decide if they need an HIV test and to assess their own current sexual risk behaviour. The website then takes their postal details and a kit is dispatched. The person takes the blood spot test and returns it to us for analysis. Results are given by text if negative and by phone if reactive. And just like with our community centre-based HIV testing services, there is full follow-up for referral into care, and we also offer a service to chaperone someone into the HIV clinic if they would like that personal support. There's further facility for reordering, for reminders if people say they want to be able to test annually or every 6 months, and to check ongoing risk if they want to have that regular testing behaviour. All of this results in much greater engagement with those who know that they're taking risks than we've ever been able to do before. Much greater than having outreach work in bars or clubs or saunas or cruising areas. So how do we integrate this with the communities that we're both drawn from and serve? Well, the community venues that we use are leisure centres, sports centres, including football tournaments for African men and African community centres, gay saunas, clubs and gyms. Some of our services are co-located with primary NHS care services, working with the NHS partners, and many within our 35 centres across the UK. They're all supported by African and gay men community outreach services, and for the postal services, we use targeting marketing on Grindr, Gaydar, African Facebook pages. And that postal service is very sensitive to marketing. You can absolutely track when we're doing a blast on African Facebook pages the number of people who go through and request a test. So briefly then, what are the results of all of this? Well, Terrence Higgins Trust is now responsible for about 10% of all the HIV tests that gay men in the UK take. That's the scale that we've managed to achieve. For our postal services, about just under 10,000 postal kits have been sent out so far. There's a very good return rate of close to 65%, a good positivity rate of 1.6%, which is comparable to the positivity rate you would expect in a sexual health clinic in the UK. But it's significantly cheaper than traditional models, up to 7 times cheaper than an NHS sexual health clinic. And what it's shown is that that kind of self-testing is highly acceptable to our target audience. And this, for me, is really exciting. The rapidly reducing costs of mobile technology and its increasing utility and ease of use will transform our HIV prevention work and the self-management of HIV by people living with HIV. Combine this with innovations in diagnostics, which will soon deliver desktop CD4 counts and viral load tests, which can be used in community settings at far lower cost than currently, opens the possibility of not just HIV self-management, but much greater HIV self-care from self-diagnosis onwards. Technological innovation in diagnostics and handheld, personally owned information technology opens the prospect of transforming HIV prevention, diagnostic, treatment and care over the next 10 years. And currently, it's worth remembering that in the UK, and I'm sure here in Portugal too, that someone who's diagnosed promptly, is stable on treatment, probably sees their HIV physician 3 times a year for half an hour. That means that for the other 8,758.5 hours of the year, he or she is self-managing their HIV. So there's a real push to ensure that we change, we don't focus wholly innovation around drugs, but also around changing service models to match current realities. So bringing it back to today, well, in fact, tomorrow, this is, as you know, the start of European Testing Week. This is part of our program, our outreach program to African communities. It's all part of a 3-year program around It Starts With Me. This is for Africans about we're testing, and you can link through from there to how you can get one of our postal tests. And of course, National HIV Testing Week in the UK started last year as part of our National HIV Prevention Programme. We're delighted that it's become European HIV Testing Week in 2013, and within the UK, more than 100 organisations, both clinical and community-based organisations, are supporting it. So I think it's an exciting time for HIV prevention, HIV testing, and HIV care, and I wish you every success in the rest of this conference in discussing all of those issues. Thank you very much.